Welcome to the online segment of this presentation on motivational interviewing, where I'll be presenting the theory of motivational interviewing prior to a practical workshop session later in October. So the learning outcomes for this presentation being to build on your communication skills so that you're able to discuss the evidence for and the theory behind motivational interviewing, and discuss the application of motivational interviewing in medical practice. I'm hoping you'll also be able to describe some of the techniques that are used in motivational interviewing by the end of this presentation. We'll be providing some small group sessions that will give you an opportunity to practice the skills that are presented in this lecture, and each of those groups will be facilitated by a skilled GP teacher. So by the end of those small group practice sessions, you'll be able to demonstrate a range of motivational interviewing techniques, and as well as that, reflect on your skills in motivational interviewing and refine these in practice over the next 3 clinical years. This session is accessible, so you may well find that there are some questions on motivational interviewing in your up-and-coming exams. I'd like just to pause for a minute and give you an opportunity to think about the last time you tried to get someone to change a behaviour that was impacting on their health. A friend perhaps who was smoking, or someone who was doing something that worried you. I just want you to think for a moment about what techniques you used to try and get them to change what they were doing. I'm suspecting that quite probably you provided them with information. You might have tried to give them all the information you knew that might scare them to change their behaviours. You might perhaps have told them how you managed to quit smoking, or whatever the issue was. Or perhaps even, since you're a medical student and you've got all the information to hand, you may have given them some useful strategies that you've read about or heard about in your medical training. I think this is a common approach to getting people to change their behaviour, the approach whereby you're trying to scare people into changing behaviour. And I'm sure that's not an approach you'd use, but it's one that you may well find in some areas of clinical practice. And I guess if we've only been trained to use hammers, and in this case we're equating providing health information and advice perhaps as being like using a hammer, then we tend to see every risk behaviour as a nail. There is another approach to trying to get someone to change behaviour, and I'd like you to have a look at this video to get an idea of how this alternative approach works.
Watch what happens this time when the provider cues in to what the parent is saying, empathizes with her situation, and attempts to work with the parent to find a solution that fits her needs.
So I wrote a prescription for antibiotics for Aiden.
Okay.
I did want to talk to you though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him. But I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job, and so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why'd you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that. All the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what? I'm not going to risk that. So
the risks were so scary then that you were able to stop. But
Yeah.
They don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
You're doing the best you can do.
yes. Yeah.
Okay, but it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's
and
on your
quitting
to-do
doesn't
list,
happen.
it's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not
Sure.
the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you, and sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure, it feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Sure.
So that's an example of motivational interviewing. So let's dig into it a little bit and talk about what motivational interviewing is. I sometimes think of motivational interviewing as a four-wheel drive approach. It's not the approach you use in every situation. You might use it where you think the going might be a little bit tricky, where someone might get their back up if you're using a different approach, where you perhaps need a little bit more traction, where you really think that there's an opportunity to work with someone to help them change a behaviour. And you certainly need to move forward slowly and carefully with motivational interviewing. It's a part, I guess, of a role continuum where you might think of the usual approach as a fix-it approach, where you give health information and advice. There is a risk that that approach might impose values and perceptions about health and disease that are those of the medical practitioner and not necessarily those of the patient that you're working with. This sort of approach is probably a pretty good example of a fix-it approach, where pretty obviously this is unlikely to meet the patient's needs. Then there's the preventive approach, and I guess that's what a lot of health professionals use, and even health professionals who sometimes use a motivational interviewing approach may sometimes do a shortcut and use this more preventive approach, and that's where you give tailored education and some recommendations that conveys an awareness of the person's values and perceptions about risk behaviours, hence the tailoring for that particular person. But motivational interviewing takes it a step further, where you're developing with the patient individualised interventions. Really comes up from the patient themselves. So you're helping patients change their values and their perceptions about the behaviour that you're hoping that they will change. So you're changing that motivation from something that's pushed by a healthcare provider to a motivation that actually comes from the patients themselves. So if you're wanting to put some terminology around it, it's directive, because we've got an idea about the goal that we want. It's certainly person-centred, and it's a counselling style that really aims to help people explore and resolve ambivalence that they may have about behaviour change. And I think you saw that ambivalence nicely demonstrated in the video we saw earlier on, where the doctor said, on one hand you're worried about smoking and how it may affect the child, but on the other hand you're not sure it's such a big problem. And it's a common experience to be somewhat ambivalent about behaviour change, particularly when it's at some cost to the individual. So what's ambivalence? And I think the example I gave earlier from the video demonstrates that it's where there are conflicting thoughts and feelings towards someone or something. It's the I kind of want to and I kind of don't want to. It's a very normal human behaviour. And we can make ambivalence work for us in our interactions with patients. How do we do that? We can work with the patient to help them recognise their own value system. And again, the doctor on the tape recognised the patient's concern about providing the best environment for the child, and yet set that against their doubts about whether smoking was the best thing for the child. So the patient recognised the disparity between the fact that although she really was fairly committed to continuing to smoke, it was something that helped her feel relaxed, but she recognised that because she'd stopped smoking during pregnancy, she was aware that the smoking wasn't so great for her child. So it's the I am here, but I want to be there type motivation. It's also about focusing on and maintaining choice. You're not pushing someone into doing something, you're helping them to make a choice and supporting them in making that choice. As I said earlier on, it's goal orientated. It's certainly not the general person-centred counselling. It's quite consciously goal orientated. You have in mind the sort of behaviour change that you would like to assist your patient to make. So you're listening for and reinforcing certain kinds of client statements that will encourage them to consider that behaviour change. Clearly not reinforcing all client statements, but selecting those that align with the behaviour change that you're trying to achieve. You've probably heard about the stages of change model, describes where someone is in terms of a behaviour change, where in pre-contemplation they haven't started to even consider the need for change. Contemplation, they're starting to think about the possibility of making this change, the pros and cons, and moving through to the point of making a decision that you will make that change, and then taking the action, making the change that you've been thinking about. And of course, with any behaviour change, maintenance is a very important part. It's not something that necessarily comes easily, and there's effort required ongoingly to sustain that behaviour change. So changing behaviour needs you to be willing and able and ready. The willingness about having a clear idea of the importance of this change. Having the confidence to change is about the ability to make that change. And then determining whether that change is an immediate priority, the readiness to make that change. And all of those are important steps in motivational interviewing, exploring the willingness, the confidence to make the change, and the readiness to make that change. So Why is motivational interviewing something that we're promoting here at Western Sydney University? What's the evidence for motivational interviewing? There have been a number of studies showing that motivational interviewing is at least equivalent and in some cases better than other treatments, including cognitive behaviour therapy or pharmacotherapy, and certainly superior to placebo and non-drug controls for decreasing alcohol and drug use, both in adolescents and in adults. Motivational interviewing has been shown to be efficacious in smoking cessation, in reducing sexual risk behaviours, improving adherence to treatment and medication, including diabetes management, adherence to antiretroviral therapy, and also reduction of substance use amongst those who are HIV positive. So a number of settings where motivational interviewing has been found to be beneficial, and you'll find references to these studies on the last slide of this presentation. So in terms of the common scenarios where you might be working as a doctor, medication adherence can be assisted by working with someone using motivational interviewing techniques. Of course, management of the SNAP risk factors, that's a key place for using motivational interviewing. But even in engagement in prevention or management programs for such common conditions as diabetes or cardiovascular health conditions, where people aren't perhaps wanting to do the fetal occult blood screening or having colonoscopy for bowel cancer, you can use a motivational interviewing approach to assist someone to make that decision to go through with that preventive health program. Certainly, as I've mentioned, management of substance abuse problems, problem gambling, sexual risk-taking, even in terms of pain management and looking at what therapies might be worthwhile trying for pain management, stress management, completion of recommended screening or diagnostic tests, or even following through with referrals. You can use a motivational interviewing approach. So how do you do it? Just breaking down some of the great skills you saw in that recorded interview. For someone who's in that pre-contemplation stage where they're really not ready to make the behaviour change, it's probably not worth a lot of time spent on it. It's just a matter of raising doubt, perhaps letting the person know a little bit about risks and problems with their current behaviour in a non-judgmental way, and maybe providing some harm reduction strategies, leaving the door open for when they are ready to start to think about making the behaviour change. So when they reach that contemplation stage, it's helping them weigh up the pros and cons of change and working on helping them to tip the balance, exploring ambivalence, and you saw that nicely demonstrated in the tape where you heard the doctor saying, on the one hand you're worried about smoking and the way it might affect him, but on the other you're not sure it's such a big problem. Identifying the reasons for change and the risks perhaps of not changing, and then increasing the patient's confidence in their ability to change. And again, in that interview, the doctor actually asked how confident on a scale of 1 to 10 the patient was about making that behaviour change, and explored with her how she'd managed to quit smoking previously. So increasing their confidence, particularly where they've undertaken the behaviour change before, that they do have some capacity for doing that again. So when someone's ready to make the change, it's about developing a plan with them. So it might be clear goal setting with a series of steps that will need to be taken towards making that change. And then maintenance. It's important to help the patient to not lose heart if they do relapse, to help them to see that that's a normal part of the progression, and that they can again put in place the similar strategies and achieve the behaviour change in the longer term on a second try. It's about helping them to understand that relapse is very normal, and you can actually use the experience to have a better go next time, and eventually to be able to maintain that behaviour change in the long term. It's often very easy when you're talking with someone to correct them or to answer things that they might say. I think when the patient in the video said, oh, but smoking's really good to relax, and some people have wine to relax, so why shouldn't I smoke? It would be very easy as a health professional then to say, oh yeah, but smoking has an impact on your child. So you resist that impulse, you listen out to what somebody says, you understand their own motivations, listening with empathy, and then you find opportunities to empower the patient to make that behaviour change. And again, the 4 basic principles: expressing empathy, focusing on the person's dilemma, rolling with resistance, like I said before, not being the one to argue for change, just hearing what they say about the pros and cons of making the change, but picking up where there's ambivalence or discrepancy, picking up where someone has presented an argument for change. I think the GP said part of you really wants to quit, and the person responded well to that statement, and encouraging the belief that change is possible. Again, the doctor in that video saying you did it before when you were pregnant, so it's possible to do it, you can do this. There's a number of tools you can use in motivational interviewing, and these are the sorts of things that you'll be practicing when you have the face-to-face session later this month. Open-ended questions, I'm sure you've learnt about these in your communication tutorials. Opening the door, encouraging the client to talk, not inviting a short yes-no answer. So asking questions like these listed on the slide. Tell me more. What's it like? What is it that you like about the effects? What would you miss if you weren't smoking, or whatever the behaviour change is? Interestingly, it's advocated that rather than often asking questions, try making statements, making a guess about what the client's saying. And I think you saw that again nicely illustrated in the videotape, where the doctor said, right now it feels too difficult to even try. When you were pregnant, the risks were so scary. So you're doing the best you can. So in each of those statements, it's making a guess about the client's meaning, and it really helps you get alongside someone. You've clearly picked up what they say, and you're affirming that. So that's the sort of question that can be turned into a reflection. The assessment of motivation, how motivated are you? How much do you want to make this change? And what's your confidence in being able to make this change? And using the scale from 1 to 10 is something that's often very useful, and can give you a guide as to whether it's worthwhile continuing, or whether you might just hang back until another consultation when somebody's, say, moved from a 2 or 3, not really interested, to more like a 5 or 6, where they may be interested. The decision balance is a really useful tool, encouraging someone to think about, well, what are the benefits of staying the same? There must be something good about what's happening for you at present. And on that same side, what are your concerns about making the change? And then thinking about the reasons to change. Are there any concerns you may have about staying the same? Or do you see any benefits in making a change? And doing that way up between the reasons to stay the same, the resistance, and the reasons to change, things that might motivate the person to make that change. Great if you can pick up some conflicting statements and use that discrepancy. I think the main conflict that was brought up with the patient you saw in the video was the decision of the mum not to smoke around the child, and the fact that she stopped smoking when she was pregnant, which indicated that she had some awareness that smoking wasn't good, and she was able to state her concerns about ear infections and asthma. So to contrast that with her decision that she would start smoking again. So evoking that discrepancy, highlighting in a non-judgmental way some of those conflicting statements, can often help someone to begin to think about what their motivation is, and whether they might be interested in changing. So when someone is starting to get ready to make the change, it's helpful to explore with them what sort of things they'd need to put in place to help them make the change. So checking out exactly what changes they're wanting to make and what the next step is. Really important to have that vision about how would you like things to turn out, but also to keep that balance of just taking one step at a time and planning with them each step. Of course, it's important always to emphasize strengths and to appreciate positive action, but that should be genuine. It's not something you say because you should. It's something that you can genuinely reflect with someone, and that certainly strengthens the therapeutic relationship when you can do that. Summaries are really useful. You can collect the information that someone has offered you. You can perhaps even link it, use that contrasting technique sometimes with something that's been discussed earlier. It often enables you to draw together where you've achieved some insights and some understanding of what the situation is, and to move on to a new task or a new topic of conversation. So you'll find a number of references for this. You're welcome to look up these references, and also further information about these websites. I'd encourage you perhaps to look at the videotape again and see how all these techniques fell together really nicely in the consultation, and to familiarise yourself with these techniques. Perhaps try when you're around the hospital, even with your friends, and we'll have an opportunity for trying these techniques in small groups when we get together later this month, and you'll have a skilled GP who can guide you in and help you to improve your techniques in motivational interviewing.